Peripheral vascular disease, silent epidemic. Big difference between academic and epidemic. So we have Dr. Rory Farnan here to speak with us today, and he is an interventional cardiologist at Essentia Health Heart and Vascular Center. He obtained his medical degree from the Royal College of Surgeons in Ireland. He completed his residency in internal medicine at the University of Utah, and he is board certified by the American Board of Internal Medicine and Internal Medicine Cardiovascular Disease and Interventional Cardiology. Okay.
Thank you. Thanks for having me. My name's Rory. My topic's on peripheral arterial disease, sometimes called PAD or PVD. If you have any questions, write them down and I'll be happy to take them at the end. So I just wanted to tell you what I was going to talk about today. I wanted to let you know what peripheral arterial or peripheral vascular disease is. Those terms can be used interchangeably. Tell you about what causes it. Tell you how to suspect that you might have it. Tell you when it might need to be treated and the ways that we can treat it. So first topic. So peripheral arterial disease is essentially cholesterol buildup within the arteries in the periphery, so outside of the heart. So I get this question all the time. People use the term arteries and veins interchangeably, but they're really not. Arteries are blood vessels that carry oxygen-rich blood away from the heart to the tissues. So a little point to note. And why do we care about this cholesterol buildup? Because it can cause narrowing, and the medical term for narrowing is stenosis, kind of like sludge in the pipes. But it can also, as Dr. Defoe described, cause enlargement, and the medical term for that is aneurysm. So much like the weakened tire, that outpouching. And we know that narrowing is more common in some arteries, whereas widening or aneurysms are more common in other arteries. Please excuse the terrible drawing, but you, my daughter did it. So usually peripheral arterial disease or peripheral vascular disease is, we kind of group it into four areas of the body: the carotids, the subclavians, the aorta, and the leg arteries as a big group. And so the carotid arteries are four blood vessels that supply the brain with blood, and the carotid arteries are the two front ones. So there's one on the right and one on the left, and they actually branch kind of underneath the chin into the internal and the external. The ones in the back are called the vertebrals. And we can see, this is a little bit of a busy slide, but this is a picture of the subclavian artery. And the subclavian artery comes from kind of underneath the breastbone and then out towards the arm. But the one point that's important is those arteries that I talked about at the back of the brain, those arteries, are those come from the subclavian. So, in the world of cardiology and neurology, we care about the brain a lot more than the arm, and so that's why we care about the subclavian artery, is because of that blood flow to the brain. As Dr. Defoe said, the aorta, call it the candy cane blood vessel. So the candy cane blood vessel, the portion in the chest called the thoracic aorta, and then the abdominal aorta, and then at around the level of the belly button, going down into those iliac arteries. So really the leg arteries start actually up in the belly, up in the abdomen. And then here are some leg arteries: common femorals, superficial femorals, and then below the knee, you can see the upside-down fork. So it's got those three blood vessels down below the knee, and they actually kind of loop together to form like a horseshoe down in the foot. So now that we know what peripheral arterial or peripheral vascular disease is, what causes it? So as Dr. Defoe alluded to, I tell my patients smoking, and then some other stuff. So if you're smoking, this is just such a big risk factor for peripheral arterial disease that it's really got to be addressed and become the #1 priority almost. Also high sugar, such as with diabetes, high blood pressure, high cholesterol, and then genetics. We can choose our friends but not our family, and that's relevant here. There's some other causes as well. Age as we get older, peripheral arterial disease incidence, prevalence increases. Also sex, so I'm going to show a diagram of that, but in the younger ages it's more prevalent in men, and then after menopause, when that estrogen, that protective estrogen goes down, you can get higher rates of atherosclerosis, so that cholesterol buildup. There's certain racial ethnic groups that tend to have higher rates of atherosclerosis. And diet, there's a substance in red meat, sorry to the North Dakota diet here, but TMAO is a substance that can lead to cholesterol buildup as compared to the vegan diet. I tried, I think, tell two of my patients to go vegan, and they told me where to go. So, and then exercise, obesity, and stress also play a role. So here's a slide, and you can see on the left is younger age, on the right is older age, and you can see that the blue, the boys, tend to have higher rates of, this is for coronary artery disease in the younger age group, but after menopause, we can see that the rates equalize, and then because there are not as many men as alive over the age as compared to women, then the women that are alive tend to have higher rates of coronary artery disease and also atherosclerosis of the periphery. So how do I know if I have it? So the carotid arteries supply blood to the brain, and so you may know it because you have symptoms. Symptoms of stroke are usually weakness or lack of function on one side of the body or the other. You may have some dizziness, difficulty speaking, but as the title of the talk alludes to, is many times this carotid artery stenosis is unknown to people, and so it's really important to see your doctor and for the doctor to perform a physical exam, and many times history is important. We can sometimes, I think, as human beings, try and explain away our symptoms and minimize, and so I think a doctor or other healthcare provider can be that objective person to say, no, actually, this probably isn't your neck. Maybe this is your arteries. Not the spine in your neck, it's your arteries. Additionally, physical exam. So your doctor or other healthcare provider may put a stethoscope on your neck and listen for a high-pitched whooshing sound, kind of like, and if they hear that, it may lead to additional testing. So this is an ultrasound of the carotid artery. We can see that the bottom of the screen is more towards your chest, and then the top of the screen is more towards the brain, and we can see it's like a Y. And on the left side of the screen, we can see that there's some white material here. This is what atherosclerosis looks like. The black is the blood, and the blood doesn't show up as echo dense. This is a CT scan, and we can see that a CT scan uses contrast dye, and the contrast can show up as white. And we can see here that there's some black or gray material, and that's what atherosclerosis looks like. MRI can also be used to visualize the carotid arteries. So which test is best? Well, ultrasound for a lot of cases is really, really good. It's quick. It's relatively low cost as compared to the other modalities. There's no radiation, and there's no risk of damage to the kidneys. CT is also pretty quick, and one benefit of CT as compared to ultrasound is sometimes ultrasound can make you think there's more of a stenosis than there is because of twisty blood vessels. The way that we grade the stenosis, percentage blockage in the carotid arteries, is we look at speeds, and sometimes a twisty blood vessel can give you a higher speed of blood and can make you think that there's a blockage there when there's really not. And then MRI, also doesn't get tricked by the twisty blood vessels. CT scan, you can sometimes, the calcium, the hardening of the arteries can sometimes come up like a sunburst and can make you think that there's more of a blockage there than there really is. And the MRI does a good job of eliminating that. And the contrast dye that's used for the MRI isn't hard on the kidneys. You can't necessarily use it in patients with kidney disease because it can affect the skin, but it's not bad on the kidneys. So what about the subclavian artery? Again, we don't really care about the arms in cardiology, but we do care about the back of the brain. And so that vertebral artery, you can see just after this stenosis, this narrowing, this cholesterol buildup here, this vertebral artery going to the back of the brain. And that picture on the right is just a blow-up of that. So how do you know you have it? Again, comes down to these same patterns, symptoms, which in our world we call the history. So what I'm going to ask my patient is if you're doing an activity with that arm, does that arm get kind of tired? Does it get heavy? But more importantly, are there symptoms from the back of the brain? So the back of the brain is supplied by that vertebral artery that comes off the subclavian. And so some people can get dizziness, some people can get vision changes, particularly when moving that arm on that side, because what's happening is the arms, the biceps, the triceps, they're sucking that blood and they're kind of sucking it away from the brain. On your physical exam, your doctor may feel both your wrist pulses or both your elbow pulses at the same time, looking for a difference. They may compare your blood pressure in your right arm and your left arm. These can be signs that that there's a significant blockage. And then also listening over that area can give your healthcare provider a clue that there might be a significant blockage that needs to be evaluated further with tests such as this ultrasound. And in the last ultrasound I showed that we didn't see a color, but there's also, you can do what's called a color Doppler, and you can put color over the area to look for the blood and blood that moves kind of without choppiness, like a calm river, shows up blue and red. But choppy blood, meaning that there's a narrowing or a stenosis, can show up kind of yellowish. And again, you can see here in this picture, this candy cane blood vessel. Here's the aorta. You have usually three branches off the aorta. This is the left. That's the left subclavian artery, and you can see here that there should be white going all the way around, but there's not. And so that's a severe stenosis here. And so hopefully there were symptoms that would guide your provider to order this test. And then what you can do with this CAT scan, which I'll get to a little bit later, is you can see how long your stent is. Hopefully the imaging just confirms what you've already found or already suspected on your history and your physical exam. And here's an MRI, and just kind of the same thing. Candy cane blood vessel called the aorta. There's a narrowing here on the left subclavian artery. So which test is best? Same kind of thing. Ultrasound is quick, low cost, no radiation, no damage to the kidneys. CAT scan's quick, but might not be available to all people because of the contrast, iodinated contrast that we use can sometimes be tough on the kidneys. And then the MRI kind of takes a while. If you ever had to, those people with back problems who've ever had an MRI, they know it's a pain in the back. So stick with cardiology, okay. So how do you know, so aortic aneurysm, and Dr. Defoe did a great talk, so I'll try and kind of go through this quickly. So again, this is the much like the carotids, this can be a very silent phenomenon. You might not know you have it. If you're having symptoms of this, it might already be too late, just like the carotid. If you're already having a stroke or a mini stroke, you've waited too long with the carotid artery stenosis. If you already have progressed to the point where you've got an aneurysm that's rupturing, that's tearing, that's you've waited too long. So symptoms of an aortic aneurysm rupture are typically this back pain, this tearing. But if we look at all the cases of back pain, aortic aneurysm rupture is much less than 1%. The majority of the time it's other things. But again, this is where, we shouldn't doctor ourselves. We should go to a person who can help with this decision making. So in terms of physical exams, where I trained in Ireland, and the rates of obesity they're rising, but they're not quite what the U.S. is. And so we learned in our physical exam, we used to put our hands on the abdomen, and we used to be able to feel the aorta in a lot of our patients, and we used to have to kind of size the aorta. In the United States, that's become more and more difficult. And the aorta does get aneurysmal, but there are many scenarios, especially with smokers, where it can actually get stenotic or narrowed. And in those scenarios, you may hear a bruit, which is that abnormal high-pitched sound that I talked about with your stethoscope when you listen over that area. And again, tests are the main way to determine whether you have it. Here's a picture of an ultrasound. The head is over that way, the feet are towards me, and we can see that this is the normal diameter of the aorta, and you can see that there's a significant enlargement there. There's a CAT scan. You can see how the CAT scan is pretty crisp, and so with the as Dr. Defoe mentioned, sometimes there is this laminated thrombus, or this kind of this smooth clot in the aorta that can sometimes trick us, and we can underappreciate the size of the aorta. The CAT scan is really good in this regards. It can really help us be quite specific in determining the sizing of the AAA. And this is just an MRI. Again, beautiful pictures with these modalities, but MRI can take longer, cost more. So I won't repeat myself, although I do like to hear myself talk. So leg artery stenosis. So as I mentioned, your leg arteries, at least in my eyes or in my brain, I think of the leg arteries as really starting up in the abdomen. Those iliac arteries are those blood vessels that start at the belly button, and you've got the common iliacs, and then the external iliacs that go down towards the hip, and then from the hip down, that's where your femoral arteries start. Common femoral, superficial femoral to the knee, and then below the knee, that's where your other ones, the upside down fork that I talked about. So carotid might not get symptoms, aorta might not get symptoms, subclavian more likely to get symptoms, and the leg artery stenosis, this is where you can really get symptoms, okay? And classically we were taught in medical school that it's usually in your calves that you might feel kind of like an aching, a cramping, a heaviness, usually with activity, getting better with rest. We were always taught about these window shoppers. They're not really shopping, but all they can make it is kind of 50 feet to the next store, and then they stop and they look in the window, and then another 50 feet, they stop. And this is the medical term for the symptom that people get, this discomfort that people get from the lack of blood flow because of a narrowing or stenosis is called claudication. And so the distance that people can walk before they get this discomfort is called your claudication distance. But it's not just in the calves. It can also be in the quadriceps, the front of your thigh. It can also be in your butt. There's a lot of patients that I've been referred to that were going to get back or hip surgery that turns out they're no problem with their hip and no problem with their back. It was really their iliac artery. And so, again, I just encourage people not to doctor yourself, to speak with a healthcare provider, because some of these things are subtle and they're even, confusing for healthcare providers. And so, we don't fault you for not being able to doctor yourself. Physical exam, a really good physical exam. Pulses are basically where the artery comes towards the surface and you can feel it. So you've got your femoral arteries, which are kind of in the groins on both sides. You've got your popliteal arteries, which are behind the knees. And then you've got two pulses down in your feet. You've got one on the top of the foot and you've got one behind the ankle. So a good physical exam will involve feeling pulses in that area, and then will also involve kind of listening over the area, because when there's narrowing, anytime there's narrowing of a blood flow, you can get this high-pitched sound. This bruit is the medical term that we call it. And so this is leg artery stenosis. This is where things get a little bit different. We do this thing called ABIs, ankle brachial index, which is just a really fancy term for saying we do your blood pressure in your arms and then your blood pressure in your legs, and we compare the ratio. And so normally your blood pressure in your legs is supposed to be a little bit higher than in your arms. And if it's not, it's usually because there's a stenosis or a narrowing. And so as you can see in the top right of the screen, they kind of give values for your ABI, this ratio, and then it can, based on the degree of the difference, you can say this is the severity of the stenosis. And there's another test that's kind of like a super duper ABI. They're called segmental pressures. And what they do is they do pressures at different levels. And what it allows you to do, if you're just doing your ABIs, you don't know between your belly button and your ankle where the blockage is. But what this segmental pressure analysis does is it can allow you to kind of isolate. Because ultimately, what I want to do is when I go in there with a wire and a stent and whatever, I want to know exactly where the problem is, so I don't have to futz around and take pictures. I know exactly where I'm going in, and I can just get down to business. And this can help you localize. The really good things about ABIs and segmental pressures are they provide a functional assessment. So sometimes a 50% can act like an 80, and sometimes a 70 or an 80 is actually fine. And these tests can really help highlight that. I'll also say, less so with CAT scan and MRI, sometimes with these angiograms that we do where we inject contrast dye into the blood vessels, you're looking at a two-dimensional image. But we know if there's an oval, if you're looking at different sides of the oval, the degree of narrowing can seem different. And so it can be very, very helpful to have these tests to help guide you, saying, because we only want to treat something if we think it's going to make our patients feel better. There's no point in making something look pretty if it's not going to make our patients feel better. So here's that. Remember I talked about this turbulent flow? My analogy is I use it like the river, like a calm river. You get the blue and the red, but as soon as there's rocks in the river, this turbulent flow, this narrowing, you can get this yellow. Again, CAT scan, and you can see a little bit, and it's not, maybe doesn't show up so clear on this imaging, but there's some calcium in these images, and these calcium plaques, that's one of the downsides with the CAT scan, and which is why when I do my assessment for leg artery stenosis, why these ABIs and these ultrasounds are really, really good, because sometimes these CAT scans, especially, who are the people who get leg artery blockages? Well, they're the smokers and the diabetics, and those are the people that have the heavily calcified vessels. And so sometimes the CT scans can't give you a definitive answer as well as the other non-invasive tests. And again, just kind of like radiation doses, 1 in 8 women get breast cancer in their lives. So I think we have an obligation as healthcare providers to try and decrease the amount of radiation that our patients get. And so here's just some pretty pictures of the MRI. So again, which test is best? I won't repeat myself. So when does it need to be treated? So carotid artery stenosis, as I mentioned, if you have symptoms, then it needs to be treated, and needs to be treated 50% carotid artery stenosis with symptoms. But if you don't have symptoms, kind of 70%. And I think something that's really important that my patients don't understand is once you've reached 100% blockage, it's a different ballgame as compared to even a 95 or a 99% blockage, because once it's 100% blocked, it can actually be more risky to our patients, risk of showering debris up to their brain to try and go fix. So I really should kind of correct that slide and say no symptoms, but 70 to 99% stenosis. In the subclavian artery, Yes, I guess if you're having arm pain, especially if it's limiting the things you want to do, but it's really those back of the brain type symptoms. And then, I think Dr. Defoe did a great job when he talked about aortic aneurysm, greater than 5.5 in a man, 5.0 in a woman, rapidly progressing, 0.5 centimeters every 6 months or a centimeter in a year. And then peripheral arterial stenosis. So, the Medicare guidelines say that we can do a lot with peripheral arterial disease rehab. So it's essentially the same thing as cardiac rehab. We put our patients, we give them a dedicated exercise program, and with this dedicated exercise program, people can develop new blood vessels. Also, their muscles get more efficient at sucking out the oxygen from the blood, and so there are many of my patients, they end up feeling a whole lot better after some rehab. Now, some of these stenosis, especially the stenosis higher up in the kind of closer to the belly button, the cardiac rehab isn't going to cure things, but it might make things better. And then, and then we have a discussion after that. Do we need to do stents or angioplasty or something along those lines? So what are the ways it's treated? So I think before we get into all the kind of the fancy stuff, the bread and butter stuff is really important. So, I said smoking. If there's no point in putting a stent in or doing an angioplasty if you're still smoking, it's just going to come back. Stent might fail. And so I think that needs to be where a lot of the focus is. But also kind of getting the sugars under control, hemoglobin A1C in diabetics less than 7, getting the blood pressure, less than 130/80 maybe, cholesterol, bad cholesterol less than 70. And then aspirin, you have these cholesterol pockets, and these cholesterol pockets can get little cracks in them, and this cholesterol can leak out. And your body, its response to this cholesterol leaking out is it kind of forms clots, and aspirin can decrease the likelihood that clots form around the area of this cholesterol leaking out. So aspirin is, and I know there's a lot of data, I think it started with the JPPP, the Japanese Primary Prevention Study. And so there's a lot of, I think, stuff in the news now about, we shouldn't give aspirin to everyone. I think that's correct, but people with known coronary disease and known peripheral arterial disease, these are people who still benefit from aspirin because it stops these clots forming where this cholesterol is leaking out into the blood. Again, exercise program is a treatment. And then revascularization. So one of the first ways that carotid artery stenosis was treated is with an endarterectomy. And so basically it's a surgery where they make a linear cut down one side of the neck, and they basically scoop out I kind of joke with my patients, like an ice cream scooper. So they scoop out the bad cholesterol, they sew back up the blood vessel, and then sew back up the skin. But there are some patients that aren't good candidates for endarterectomies, and those are people usually if they have 100% blockage on the other side, if they've had radiation to the neck, if they're just kind of so sick with other comorbidities or other healthcare conditions where they wouldn't tolerate like the breathing tube being put on the breathing machine for the procedure. Those people, we can do a stent, and so we usually make a poke in the femoral artery, the artery of the groin. We go up, put a wire up, inflate a stent, and take down the stent and get out. I won't belabor this point because Dr. Defoe did a great job. And this is the aortic stenting. And I, with the subclavians, it's a similar thing. We place you can do bypass surgery, but subclavian arteries are relatively easily treated with stenting. And then in terms of the legs, bypass surgery was the mainstay of treatment for leg artery blockage for a long, long time. But I guess in my humble opinion, I think that this has really taken a back seat. I think that we can do a lot of really great things percutaneously, so kind of fixing things from inside the blood vessel. And this is not a great example, but there's about a 70%, 50-70% blockage in that mid blood vessel. And in the last kind of less than 10 years, we used to place stents to open up narrowings from cholesterol. But what we found is that angioplasty and not just angioplasty with balloons, but balloons that have basically medicines on top of it. So what we do is we inflate the balloons, the medicine seeps into the tissues, and then that stops that cholesterol from kind of reaccumulating. It stops the development of new blockages in that same area. So those are called drug-coated balloons. There was some suggestion that maybe these medicines on the balloons might be, causing harm to our patients, but in a lot of like meta-analyses where they look at like thousands and thousands and thousands of people, that hasn't really panned out. And so, there are a lot of different blood vessels, places where you can enter the body, enter the blood vessel to, in order to put the stents of the balloon. You can make a poke in the groin arteries. You can make poke in the behind the knees, and you can actually make pokes in the feet and go up towards the groin. And your proceduralist, whether it's your Adam, whether it's myself, Dr. Strav, they'll kind of make the best determine what's best for you based on your specific case. So in summary, peripheral arterial disease or peripheral vascular disease, what is it? It's a cholesterol buildup in the arteries. It can result in narrowing or widening of the arteries, usually narrowing other than the aorta, often seen in the neck, abdomen, legs. Symptoms can sometimes tell you if it's there, although in the carotid and the aorta you might not have symptoms. And then treatment starts with treating the underlying causes. Again, smoking. Stop. And your healthcare providers can recommend invasive treatments for you if they see fit based on a lot of really good data. So, thank you.
Any questions for Dr. Farnan?
I just had a question. A couple of years ago, a coworker of ours, late 30s, early 40s, was putting off the leg pain she was having, and she did pass away. So in that case, most likely a clot. Did that travel up to her heart then, maybe? Is that what the big concern would be?
So a couple things about that. I don't know the specifics of the case, so a lot of this is speculation. But usually peripheral arterial disease is not going to be present in a 30 or 40-year-old. You got to have some very unusual, finding. You got to have like a vasculitis or something along those lines that is very rare in the population for a young person to have an artery problem. And so this peripheral arterial disease, I don't think that this individual probably had that. Now, could they have had a vein problem, a vein clot? Potentially. And then the vein clot, could that have gone to the lungs, causing a pulmonary embolism, a lung clot? And that could very well be it. But I don't know if I have enough information to say with certainty.
Dr. Farnan, could you talk about the prevalence or how common peripheral vascular disease is in comparison to heart disease and other diseases?
Ah, great question. So it's and I think it was spoken about in one of the other talks. I think there's a lot of times that our patients they blame their symptoms on getting old, and I think that that's not always the case. And I think that a healthcare provider can help you determine whether that's the case or not. And so what I find with my patients is very often they'll modify their activities. And so they won't get the leg pain because they're not as active as they once were. And they're just saying, oh, well, I'm old and I can't walk that far. Well, if you work with your healthcare provider, they may be, and it's as simple as doing a physical exam, and maybe those ABIs I talked about, that maybe we increase their walking. So it's definitely underappreciated, and I think part of it is, I think healthcare providers are sometimes stretched thin. There's about 4 or 5, concerns that the patient has, and we try and address these things, and then and then sometimes we don't get to take off the socks and the shoes and do the pulses and look at the feet, and and then sometimes our patients are in wheelchairs, so it can become difficult. So I would just encourage our patients to even walking around at home, and if you're walking up a flight of stairs, kind of listen to your body. Is it really because you're old, or maybe you're something that might tell you that you have a leg artery blockage is like one side of the body worse than the other. Blockages don't, they're not symmetrical. They don't, and again, that the discomfort that's worse with activity gets better with rest, that window shopper I talked about. And then, progressing on from that, there's the claudication that I talked about, that discomfort in the calves, sometimes the quads or the buttocks. And then if it gets really, really bad, people can get leg discomfort at night. Now, I know that a lot of people have leg discomfort at night, and a lot of it is restless leg syndrome, but there's also, I ran a peripheral arterial disease clinic, and there was, much as I saw a lot of people who had, hip or spine pain that was really peripheral arterial disease, there's also a lot of people out there with restless leg syndrome that might be due to the veins or the arteries. And so, it's taking the holistic approach. Now, of all the people with restless leg syndrome, what are the proportion that have peripheral arterial disease or vein disease? Probably, not the majority, but sometimes it's just brushed off. And so at least it's should be considered. And that's not faulting any of the healthcare providers. Again, people are busy, stretched thin.
Okay, I'll move this side of the room.
In regards to the cigarette smoking, is it the stenosis caused by the nicotine part or the cholesterol atherosclerosis buildup?
So it's what I tell my patients is inhaling anything other than air is bad. And so because there are several people who might not, I don't smoke cigarettes, doctor, but they might smoke something else. And so it's really those inhaled particulates. There's a lot of data to suggest, there was forest fires. It was, I think, this past summer. There was, at the Beijing Olympics, there's these inhaled particulates, just like oxygen is picked up from the lungs. These fine particulate matter is picked up. It goes into the blood and it gets transported to the tissues. And this, I kind of tell my patients, it's like a rug burn. It kind of irritates the inside of the blood vessel. And then the way that the body responds to that is it responds by building up cholesterol, which is kind of funny. Well, I don't know. Maybe but I would think like the only thing that causes cholesterol buildup is cholesterol, but there's actually a lot of things, and these inhaled particulates can do it. But nicotine, they can cause some vasospasm or contraction of the blood vessels. But the cholesterol buildup is a lot to do with the microscopic stuff. So pollution, inhaling cigarettes, inhaling other stuff.
You didn't bring up the use of statins.
Yes. Treating causes. I absolutely agree. Yeah, absolutely. So statins, so one thing that I tell my patients, I have this analogy, this cholesterol pockets. So what statins do in cholesterol pockets of the heart, of the legs, is yes, they prevent new cholesterol deposits from forming. But many times I'll hear my patients say, well, my cholesterol is good. I don't need a statin. You probably do, actually, if you have coronary disease or peripheral arterial disease, because what it does is it turns the cap of the cholesterol pocket from like tissue paper, it can turn it more towards leather. So remember I talked about these fissures, these cracks in the cap? These cracks in the cap, especially in the heart, they can lead to these heart attacks. And the statins, the medical term, pleiotropic effects, it stabilizes these pockets, so there's less cholesterol likely to escape, less heart attacks, less strokes, less acute closure of leg blood vessels. So very, very important. Good point.
Okay, well, thank you, Dr. Farnan.
Okay, thanks.